Thank you. Good evening to all those who have logged in. And there's never a dull moment when it comes to the Uro-Oncology section of the Urological Society of India. The web platform which they have created for education is, I think, most looked forward to and most cherished. And even a hardcore general urologist like me is getting some inputs on almost, I would say a weekly basis. And a lot of things are getting rubbed on to many of us. And I'm sure this will show up as an increase in the membership. I must thank the leaders, Dr. Amit Ghosh and Dr. Ravi Mohan Mauduru, for doing such a wonderful job. On behalf of President Dr. Sanjay Kulkarni, who is in Chicago, he's left a little ahead of all of us for the AUA meeting. I welcome all of you for this webinar on locally advanced bladder cancer. And it gladdens my heart when I say that there is one genitourinary malignancy where you cannot do away with the cystoscope, and I think it is the bladder cancer. And cystoscope and urologists are, they're intertwined. They are inseparable. It is the cystoscope which established the urologist's commitment to the cystoscope and devotion to the cystoscope probably made the urologist a professional and urology a specialty of its own. I will not go back into the history with this opening remarks. Greetings from the Council of USI over to the chair of the National Chair of Uro-Oncology section, Dr. Amit Ghosh, to conduct the proceedings. And we are all ears and we are eagerly looking forward. Again, a special welcome to Harshit. It's such a pleasure having you, Harshit, here at a time which is, diametrically opposite. Thank you very much for being here.
Thank you.
So we are so proud of you and your achievements. And
Thank
the
you,
treasurer is there, the national treasurer is there. Welcome, sir. And so many of my friends I can see, Balachandra Kashapi, Anand, Ganesh Bakshiji, so many of them. And with that, I think, over to Dr. Amit.
Good evening, everybody. Thank you, Dr. Lakshman Prabhu. You have always been very kind towards uro-oncology. We are trying our level best. We have not reached the targets that we aim, but we will. I will take this opportunity to talk shop a little bit because it is necessary. We, under the circumstances, we were born on the 2nd of February this year. And we, as you all know, we are targeting our annual conference on the 9th and 10th of July. And there also we have had a heavy jolt, after which we've settled our conference to be having in New Delhi. I appeal to all of you repeatedly, and I'm going to do this repeatedly from now on, because we are approximately 6 to 7 weeks away from the conference. Please self-register. It encourages all of us in the Uro-Oncology Council if you do so. I don't think we should wait. That's number one. Number two, please pour in your ideas or objections to whatever we are doing. Let us not criticize post-event. That's an appeal. In the process of doing this humongous task of conducting a national conference in a notice of 2 to 3 months, we will make mistakes. There will be miscommunications. There will be faults. I mean, that's only expected. The reverse is not. Perfection is the target, but we will definitely make mistakes. So please feel free to criticize us. Feel free to warn us, because we are not in any elevated position from any one of these members who are watching us. Maybe I'm the chairman or Ravi is the secretary and there are council members, and nobody is in an elevated position. We're all in a same platform. We are doing it all together. This is something we need to understand. And therefore, any faults or anything that can be averted and circumvented, please warn us. From my side, the warning is we are designing a very, very ambitious program. We need your help in trying to coax the industry into making this a success. And that is each one of your responsibility. Please do not criticize us later for all the failures that we will have. I'm telling you, it is going to be a reverberating success. But there will be failures which are criticizable. This is the first time we're doing it. And problems in this sort of things are inherent. One thing we have decided, we have, just to make this whole thing more aware, our presence more aware and felt, we had designed weekly or bi-weekly or bi-monthly webinars. We've disturbed everybody, very busy people, faculties like, Ganesh Bakshi, and, even senior people like Amlesh Seth and who not, NP Gupta. We've bothered everybody, but for the welfare of this section. But we're going to stop now. Whether we are going to do one more conference is still debatable. Stop, because we really need to focus our time and energy and all efforts towards the annual conference. Please do not take this opportunity to forget the agenda that we have all set for. My appeal, I repeat, from tonight, please register. It's a new association, it's a new section. If you don't register or defer it to a more convenient day of yours because you're busy, it only dampens our spirit and the spirit of the section. That's the theory part of it. Let us come to the pleasant part of it today. We will have a very vibrant session of 1 hour. I have taken a little bit of time deliberately because it is necessary. For 1 hour from now, we promise to finish, it's 10 past 8 nearly. We promise to finish by 5 past 9. And we will first have a talk session from Harshit Garg, who is one of us stationed in US at the moment doing a fellowship. He's going to give a talk on advanced bladder cancer management. I hope it is in congruity with modern times, but I'm also hoping that there will be things said which are compatible with Indian practices. Following that, we have the Maestro Ganesh Bakshi, who is going to deliver a panel discussion on this subject. We have great expectations, Ganesh, but for the moment, over to you, Harshit.
Thank you, Dr. Ghosh, and thank you, Dr. Mohan and the Executive Council for giving me the opportunity to talk on this very exciting topic of today's world, that is locally advanced bladder cancer. I hope my screen is visible to everyone. Okay,
Yes.
thank you. So this is a Herculean task because, we all know that we are in very exciting times of bladder cancer and we have a lot of development happening. And, I just witnessed the SEO and then ASCO the last 3-4 months. And there are so many sessions on this thing. So I'll try to briefly go over everything, what we have today and what we'll have in next 5 or 6 years. So, and I'll try to restrict to my time. So disclosures are none. A quick outline would be the introduction, definitions, what are the current guidelines, what are the novel treatments, what are the challenges we are facing, and a quick summary on where are we today. A brief of bladder cancer snapshot. We all know this is from the United States point of view, but grossly the 5-year survival of overall bladder cancer is in the range of 77%. And if you have a metastatic disease, is in the range of 6%. We all are aware of the risk factors. The only thing which we have seen over the last 10 years is that new cases have been falling by an average of 1% per year, as per the statistics from the United States. Staging of the bladder cancer, this is the 8th AJCC staging. We are all aware of it. But when we talk of locally advanced bladder cancer, mainly we are talking of T3 or T4 disease, or clinically regional lymph nodes, that is N1 to N3 disease. So that will be the focus of this today's talk. Now, there has been a paradigm shift in this locally advanced bladder cancer because in 7th AJCC, the N1 to N3 was classified as a stage 4 or a metastatic disease, which was later realized that the nodal mets are not essentially like a metastatic disease, and hence they were downstaged to stage 3. And that's why there's the whole new chapter of locally advanced bladder cancer picked up the momentum, because now it's no longer considered as a metastatic disease, frankly, as per the new staging. And so this is one of our, I know we have a case scenario and a panel discussion, so I'll just briefly show you a patient we operated 2 weeks back. And so this is a patient of a locally advanced bladder cancer. It was involving the sigmoid colon, of course, the vaginal wall. And I could not get the specimen picture, but we have the pathology picture of this specimen, and we can easily appreciate the cancer cells infiltrating into the colonic mucosa, and it was staged as a PT4A N2 disease. Of course, this patient also had a inguinal lymph node palpable, which came out to be positive, and all the pathology was a squamous cell carcinoma. So variant pathology per se is another challenge, but just to give you an idea that why are we talking of a locally advanced bladder cancer? So this picture is from Italian Alps. And as you see, there are a lot of mountains in this, which a lot of peaks and troughs. So I don't know if anyone of have read about our geography or geoecology, but these troughs in the mountains, we call them cols, or the gaps between the mountain ridges. And something similar to this are we dealing today. We have a lot of stuff happening in the field of localized bladder cancer. We have a whole array of BCG-resistant therapies, treatments, and we have a lot of stuff going on in the metastatic bladder cancer. But where we are stuck in between is the locally advanced bladder cancer. And that's the gap or the unmet need we are trying to fill. And what is eventually happening is whatever the information we have got from the localized and the metastatic disease is being implemented to find the management suitable for the locally advanced disease. This was, many of you would have read this paper, many of us, in 2000s when Haringer published that, you can do a cystectomy in a grossly node positive patients and you have 24% survival rate. And then came the era of integrated therapy, which was this paper from MD Anderson in 2001, where they said that if you give chemotherapy along with cystectomy, it improves the outcome. So this was the time, early 2000, when we were trying to find an integrated approach for the locally advanced bladder cancer. But we were troubled with some things. That is, we had research funding, which was limited. We had lack of public awareness. We did not have any novel therapies, and the biology was still being understood. But today, as we talk of locally advanced bladder cancer, we talk in terms of T3, T4A disease, or clinically N1 to N3 disease. And I'm sure in this Council of Uro-Oncology, most of us are aware of these definitions as I shown in the previous slide. So I'll not delve into details of the staging. And so let's start, where are we today? So in today, as per the latest NCCN guidelines, when I see about stage 3A locally advanced or stage 3B locally advanced, both of them essentially means that you give the patient some sort of systemic therapy, and if they respond, you give them consolidated treatment in the form of surgery or a chemoradiation therapy. And if they don't respond, you continue to second-line systemic therapy. So that's, in a crux, that's the current management of LABC, that is locally advanced bladder cancer, as per NCCN. But is it that simple? Of course not. We have a couple of issues with this. And the biggest issues is the platinum-based therapy, which is the backbone of our systemic therapy. We are having issues with the ineligibility of cisplatin, toxicity, poor response, biomarkers, limited knowledge about the novel agents, and whatever information we are having, we are just trying to extrapolate from the metastatic settings. Apart from that, even when we do consolidated treatment, are we giving any survival benefit? This is still in question. And further, to jeopardize, our urologist or surgery, this editorial in European Urology saying that, is it time to consider eliminating surgery for the treatment of locally advanced bladder cancer, further sparked the debate as, are we surgeons be going out of business today? So let's see, and let's try to be in the business. And so today, my talk, I'll divide in two sections. The first, in the advances in the systemic therapy, and second, what the recent data says on the survival outcomes on this multimodality treatment. So in the systemic therapy in the locally advanced bladder cancer, we have predominantly derived the data from the metastatic settings and extrapolated it. And so there are two terms we often use, that is a neoadjuvant systemic therapy or an induction or a downstaging systemic therapy. Whenever we use these two terms, they're often interchangeable because whenever the patient of an LABC is coming to us, we are trying to give him some sort of systemic therapy. But conventionally, if it is stage 3A, or when we are planning to do a surgery for this patient, we call it a neoadjuvant therapy. However, if we are not sure about the next subsequent course of the patient, or it's in stage 3B, we just call it induction or downstaging therapy and see the response and then decide the treatment. This is, the landmark paper from 2003, where they said that neoadjuvant cisplatin-based chemotherapy improves the survival, which was followed by these, famous ABC meta-analysis, and the numbers we all know, that the 5-year overall survival benefit of 5% and disease-free survival benefit of 9% with the neoadjuvant chemotherapy. But there are certain advances in the neoadjuvant chemotherapy field per se, which has, started from MVAC and gone to dose-des MVAC. So first and quick, glance on the dose-des MVAC therapy is, preferred regime right now because of a safer safety profile, shorter time to surgery, and a similar pathological response rate. These are the two trials, the Coxsackie trial and the Vesper trial. Both of them, have favored a dose-dense MVAC. And with this, the current NCCN has also favored dose-des MVAC as a neoadjuvant chemotherapy for these patients of locally advanced bladder cancer. Now, good, we have the cisplatin, we have the MVAC, but we have a couple of issues with cisplatin because we have a definite criteria for determining cisplatin eligibility, which includes a good performance status, a good creatinine clearance, hearing, neuropathy, hearing loss, and, good cardiac condition. And what it leads to is 50% of the patients approximately become cisplatin ineligible. And then when we give it carboplatin, it also has not, have equivalent outcomes as compared to cisplatin. So then the world came, to have to find something new or novel. And then we talk of this immunotherapy, which is all around the globe right now, all over the industries, that is cancer immunotherapy. Now, as surgeons, it was always very difficult to understand, in a glimpse, what is exactly cancer immunotherapy. And I know for my friends and young colleagues who are, not very familiar with the concepts of the immune checkpoint inhibitors or the novel immunotherapy, this cartoon would explain them in a single minute. Here, quickly, the pink is the cancer and blue is my, the T cell. So whenever the T cell is trying to identify the cancer cell uses its PD-L1, which is, like a harpoon, trying to hit the T cell, and hence the T cell dies and the patient is not able to respond against the tumor, and the tumor evades the immune response. This is the mechanism basically used to find out immune checkpoint inhibitors, which is PD-1 blockage or PD-L1 blockage. So PD-1 blockage is just like giving helmet to our T cell so that the cancer cell cannot kill it, while PD-L1 blockage is just, bubble wrapping the weapon of the cancer cell so that it cannot kill the T cell. And in both the scenarios, the T cell is effectively able to kill the cancer cell. And then we have so many tongue twisters. When I started my residency, they were actually tongue twisters. Now people are talking so much of them. They have become now normal nomenclature in the field of uro-oncology, which are like atezolizumab, pembrolizumab, ipilimumab, and tremelimumab. So they're PD-L1, PD-L1, and CTLA4 inhibitors. We just have to, just to give you a brief on which are the inhibitor and which are the drugs associated with them. Now, the landscape of the immunotherapy in the bladder cancer started from the metastatic setting. And we all know that why immunotherapy in bladder cancer? It was derived from the melanoma, because bladder cancer is known to have a lot of mutations, high mutational burden, similar to the melanoma. And so we extrapolated that immunotherapy could work in the metastatic or, in a urothelial carcinoma. This slide gives you the glimpse of all the trials which were there in the metastatic settings. I'll not go into these details, but we know the Keynote 361 and IMvigor 130, wherein they both showed that overall survival is similar between the first line setting in the immunotherapy monotherapy, or if combined with chemotherapy arm. But there was some idea that the immunotherapy might have less toxicity. However, immunotherapy looks good every time, but it's not a gold mine, And this is on November 29 last year that atezolizumab was withdrawn from the FDA for this indication based on the failure to meet the post-marketing requirements necessary for the accelerated approval of atezolizumab. So that is, it is not that immunotherapy is always going to be successful. And so we have to look on these things very skeptically. Apart from, so once we have talked about metastatic settings, two major trials. One was Checkmate 274, which talked about the adjuvant nivolumab in the setting of bladder cancer. And second was adjuvant avelumab for Javelin 100 trial. These two trials were already there with us in past 2 years. And these have shaped us our guidelines of today, wherein if we are giving the adjuvant therapy for patients with PT3, PT4A, which is essentially locally advanced, or a PN plus disease, adjuvant nivolumab is recommended, irrespective even if the patient has received prior cisplatin-based chemotherapy or not received prior cisplatin-based chemotherapy. Similarly, in the first-line setting for the metastatic disease, if the patient has a stable response, then they're also advised to continue on the maintenance avelumab for 1 year at least. So since we have so much already available, so what next do we have in locally advanced bladder cancer? And so this is the next phase, that is the neoadjuvant immunotherapy. We are still limited on the data of neoadjuvant immunotherapy. This was a beautiful review published in European Urology Oncology last year, wherein they tried to assess or narrate the evidence of the phase 2 and phase 3 trials on the neoadjuvant immunotherapy. This table summarizes the data from the neoadjuvant immunotherapy in combination with platinum-based therapy. What I would like to highlight, there are very small number of patients with a phase 2 trial, and the response rate has been range of 30 to 45%, which response rate is defined as the pathologically the disease has become 2-0 or a complete remission. Similarly, this is the data of the various studies assessing only the immunotherapy alone, and the response rate has been in the range of 30 to 35%. Remember, all these are phase 1 or 2 trials, no control arms, very limited, extrapolation to a clinical setting, but they give you some hope that there is, some chance in this case in neoadjuvant immunotherapy. I would just briefly cover this one trial that is from Netherlands, which is Nabucco trial, where they try to assess again Nivo with IP, and they also showed around a 46% pathological complete response. This slide again summarizes the combination of the immunotherapy with the chemotherapy. I know sometimes it becomes very boring for our surgeons, that there are so many trials, so many numbers, and how to catch up with this, medical oncologists who are always into these things. So we should I'll just briefly touch on two trials. That is a BLAST trial. So the BLAST trial is one of the trials from the University of Minnesota with Dr. Conetti as his PI, and they're trying to study the effect of GemCis with Nivo, and they had reported earlier the PT0 34%, but now as per the updated results, they have the progression-free survival of around 83%. Similarly, another trial from the Switzerland, which is SAC trial, which is studying durvalumab with GemCis, have also shown that primary endpoint was met with a 76%. So mainly we have to, as a surgeons, we need to understand that these things are working, and the response rates are, as the follow-up is increasing, the response rate is increasing. And one interesting thing which BLAST trial just showed on the molecular typing is that the basal type tumors, are responding better to the immunotherapy. But phase 2 trials are not enough for, strong evidence to do practice clinically. And so we need phase 3 trials. And this summary, I think I have only this one slide because most of the phase 3 trials are still ongoing. There's a whole array of phase 3 trials with cisplatin ineligible and cisplatin eligible patients. I don't want to go into these details of every single trial and just bore you, but we should have an idea that there are a lot of trials, Keynote, Niagara, Energize, which are trying to study the combination of chemotherapy with immunotherapy. And so the results are still waiting. And so we have very exciting times ahead. And who knows, the neoadjuvant immuno just becomes the standard of care in next couple of, years. Now, another problem with this immunotherapy is who would respond and who would not respond. And one of the review tries to look on that. And we have various suggested markers for immune checkpoint inhibitor therapy, which include, activated CD cells, PD-L1 positive status, high tumor mutational burden. And we have also some markers for resistance, which includes TGF-beta or fibroblast-associated proteins, but nothing is for definitive right now. And that's one field where we have to really look into that whether if we are delaying this surgery, whether this patient is going to benefit from neoadjuvant immunotherapy. And as with platinum therapy, it's not that immunotherapy has no side effects. And you see, all the various studies, the side effects seriously reported between 50 to 70%, if any grade, and around 20 to 25% when we talk of severe side effects. So is that all? When we have all talked about immunotherapy, should we stop there? No, man, we have to go on. And so as the NCCN has new, more targeted therapy, drug antibody conjugates, and so we have a couple of new agents in our armamentarium for fighting this advanced bladder cancer, and they are the antibody drug conjugates or targeted therapy. So, it was always very difficult as a surgeon to understand what is, antibody drug conjugate. So I thought I'll just put this diagram. So in antibody drug conjugate, this is an antibody I think we all remember from our med school days. So this antibody binds to a specific antigen because it has an antigen recognition site. And this antibody is then attached to the drug, which is, essentially a chemo drug or something like a cancer inhibitor drug. And right now, we have two drugs for the bladder cancer, which are, at pace and often approved, which are enfortumab vedotin and sacituzumab govitecan. So we call that EV and SG. So EV has basically an antigen is Nectin-4, and it is an anti-microtubule inhibitor, while SG, the antigen is TROP2, and it is a topoisomerase 1 inhibitor. You remember these things from chemotherapy mechanisms of action. So talking briefly about the EV, so EV has been there for like 3 or 4 years now at least, and it's pretty commonly used in our center. I know it's not yet very commonly used in India, but it will be soon available in India, I hope so. I think people can enlighten me on later on this. But so EV was first approved for a locally advanced or metastatic cancer with a previous treatment of a platinum and an immunotherapy. But later on, it also got approved for just a platinum naive setting based on only immunotherapy failure. So we have got EV301 and 201. And now, which is recent, is EV103 trial, which is trying to look upon upfront previously untreated cisplatin patients, which are cisplatin ineligible, but like first line. And this trial per se has two cohorts, cohort A and cohort K. Cohort A is a single arm cohort in which we are giving EV and Pembro, and it showed a good response, around 73% overall response rate. And this is the cohort K in which it was compared, EV Pembro was compared to EV alone, and EV Pembro combination showed a significantly better response as compared to EV alone in this setting. And that's latest on April 3 this month, FDA granted the accelerated approval to EV with Pembro for locally advanced or metastatic bladder cancer, which can also be used for a downstaging systemic therapy. So that is the latest right now we have in the armamentarium, EV Pembro for cisplatin ineligible first-line neoadjuvant therapy. Now, EV is not a wonder drug. It has a lot of side effects, which includes hypoglycemia, pneumonitis, neuropathies, and ocular disorders. And then the second thing we have in the armamentarium is the targeted therapy. The target therapy we all have learned, FGFR. We have wise information from kidney cancer. Similarly, we have FGFR 2 and 3 mutations in the bladder cancer. And so one of the major inhibitors is erdafitinib, which in the trial was shown to be, have a higher response rate for those people who have FGFR3 mutation or gene fusions and at least one prior chemotherapy. And right now the guidelines stand there, but we are still exploring this to expand its horizon for use. Again, for the erdafitinib, we have hyperphosphatemia and chronic serous retinopathy as the predominant side effects. The third one, and I think the last one, after that, I think I'll not bore you with more of these complex tongue twisters, is the SG or sacituzumab govitecan. The TROPHY-1 trial really led to its FDA approval. And, it's not that common, but we have certain patients which medical oncology gives them SG. So these are the patients who have advanced cancer with prior failure with the both immuno as well as the chemoplatin, platin-based chemotherapy. SG, you have to have certain side effects be aware of, which is basically neutropenia and severe diarrhea, apart from the hypersensory reaction. So once, we have done all these, chemo agents, and finally we are doing surgery, but are there any options of bladder sparing treatment? So one of these recent reviews in 2022, which was trying to assess the role of immune checkpoint inhibitors with the bladder sparing chemoradiotherapy. And there is a thought process going on that immunotherapy could be synergistic with chemo and radiation, because radiotherapy can enhance the expression of the PDL1. It could, of course, enhance the inflammation states, so will improve the immune cell infiltration and antigen presentation, as well as chemotherapy can also help in depletion of the immune suppressive cells. These are all mostly hypotheses or very pre-experimental evidence. We don't have very strong evidence to support this, but there is something to suggest. There's a whole array of trials, around 15, 16 trials ongoing with neoadjuvant immuno with radiation concurrent. So, the results are still awaited, but what our preliminary results are showing to us is that they have limited patients, but the 1-year survival is happening in the range of 80 to 90%. The data is still premature, is still limited. So, we have to wait until we make any definitive conclusions or inference from this. Apart from this, there are various regimes or dosing schedules they are having, when to give immunotherapy with radiation, either before, after, or, together. So all this is still, under, experiments underway, and we still don't have any definitive answer for this. With this, advances in the systemic therapy, let's talk briefly about the survival outcomes and what our recent data is showing. So this was one of the data analysis from the National Cancer Database done one of my friends from the MD Anderson, Dr. Sood. So he's also an AIMS alumni. So they try to look on all the clinically node positive patients and whether they would benefit from high intensity treatment, which they defined as surgery or a definitive concurrent chemoradiotherapy, as compared to only systemic therapy. And what they found that yes, there is a definitive survival benefit if you give these patients, high intensity treatment. The problem was, we all know that in stage 3A patient, that is clinically node 1 patients positive, neoadjuvant chemo followed by surgery is a definitive, treatment. And 60% of this study population was CN1. So results would be in the favor of a high intensity treatment. So we thought to relook on this. And we tried to study this manuscript in a publication right now in Frontiers. So try to look on the comparison of the contemporary strategies, which could be the surgery, concurrent chemoradiation, or just systemic therapy in locally advanced, that is clinically N2 or N3 bladder cancer. And the results actually look the same. Whenever the surgery or a definitive radiation therapy is given, the survival, there is a definitive overall survival benefit with a median overall survival rate of 20 months compared to 14 months when they get only systemic therapy. However, there was no difference between the surgery versus the definitive concurrent chemoradiation. So I think these results, match the current literature or current thinking that both these things are feasible options and of course are better than the systemic therapy. One of the major bias when we talk of it, because those patients who would have not responded to systemic therapy, they would have not given the high intensity treatment. Hence, they would have always done the bad side. So that's a bias which is there automatically, that those patients who received only chemo are the ones who are actually not getting benefited. That's why they're being continued on the chemo or immuno regimen. And this is one of the last, few slides. So we try to look on this in bladder cancer, whether this immunotherapy is really trying to actually improve the survival benefit. And so we just plotted the, survival for year wise. And we know that the immunotherapy is increasing, the red line, and the chemotherapy use is decreasing. And to our surprise, as we always talk in the trials, that the immunotherapy gives a benefit of 3 months. So when we checked it from the chemotherapy era to immunotherapy era, we also found that the actually average median overall survival benefit was from 9.9 to 12.5 months. So it's, the 3 months benefit in the metastatic setting when you are giving the immunotherapy in the a metastatic setting. So let's quickly, summarize everything what we have done, discussed. So this is one of the opinion-based, algorithm published in European Urology Oncology for a locally advanced bladder cancer. So first thing is, if you give a first-line platinum or first-line systemic therapy, if you have a complete response or a partial response, go ahead with the surgery. And if you cannot do it, then you give maintenance avelumab. If there is stable disease, it has not responded, it's a bad sign, you just continue maintenance avelumab. If you have progressed, try for a clinical trials. Now, if you have given the patient with the intent of neoadjuvant chemotherapy and you have a complete response or a partial response, even stable disease, you just go upfront with the surgery or a definitive chemoradiation. But if the disease has progressed, you try to get him into the clinical trial. And so we always talk of this team approach and shared decision making. I don't need to stress this more, but I would like to emphasize is a closed loop communication. Radiation oncologist saying something, surgeon saying something, medical oncologist saying something, and a patient is getting some information randomly from here and there. Everything should be bound in a closed loop. And so we have a lot of unanswered questions right now, which talks about efficacy, the synergistic effects, biomarkers, what is the optimal schedule, whether the pathological complete remission will improve the overall survival or not, what are the stages of the upfront comparison of neoadjuvant immuno versus chemo, how to continue, and of course, the cost effectiveness. And with that, I say, our biggest challenge is that we have a lot of data, but we have to turn this data into wisdom. And with that, I end. Thank you. Thank you so much, USI Uro-Oncology Council, for giving me this opportunity. I'm happy to answer any questions if anyone has. And I think I try to restrict myself on time, I hope.
Yeah, thank you. Thank you, Harshit. It was a very enlightening lecture on a topic where actually you, as mentioned in your talk, that it's a big trough. And we're trying to fill in from both the localized and metastatic cancers. And I think the times are exciting that eventually we would have much clearer answers. And you covered almost all the aspects with respect to managing locally advanced bladder cancer, including its role with respect to surgery and radiotherapy once you have started on with immuno and chemotherapy. So I don't see any questions in the chat box. So let me start you with one question. What is the practice there at MD Anderson where you're practicing that?
I think our standard practice is if you have a urothelial pathology, so we would upfront give a neoadjuvant platinum-based therapy. We assess the response in 3 months. And PET is pretty common here. Actually, we all do PET scans very commonly. And if they have response, we just based on the decision making, whether he's going for chemoradiation, definitive treatment or high intensity treatment. If he is not responding, then they switch immediately to the immunotherapy. Our medical oncologist is not a very big fan of carboplatin right now here because the data is not very supportive of carboplatin, and we have insurance covered, immunotherapy. Even sacituzumab is covered right now in FDA approval in insurance. So they would gradually upscale it with immuno. Then immuno plus chemo combination based on the medical oncologist practice. Then they would, they are more receptive for enfortumab EV. And recently we had one patient, they even give SG, sacituzumab, that's very not common because they're still having a phase 3 trial here on that. But so that's and I think the patient I showed you, that patient had a squamous cell carcinoma involving the rectum. And so there was a lot of debate, whether we should give preoperative platin or whether we should give radiation therapy. But the consensus was, to just go ahead with the surgery first. And, we can do everything in the adjuvant setting because there is no definite evidence in neoadjuvant setting for squamous cell carcinoma bladder for, these things. Thank you, sir.
So Harshit, I have a question. You said you would offer bladder preservation. So how do you select for that apart from counseling?
So as surgeons, it's a very, apart from counseling, we have those criteria, that this tumor is the standard criteria.
Bladder cancer, we always feel that surgery is slightly superior.
So we also feel the same thing, I think, as surgeons. We always feel the same thing, but we have a multidisciplinary board. And a lot of patients actually, the way radiation oncologists, they have this no upper tract hydronephrosis, no large extravesical extension grossly. They would not do the radiation, but they have the radiation data is strong enough to suggest that their outcomes are, okay. And it just mainly depends on patients. We always get them to see radiation oncologist, and we don't have any specific answer, how do we select our patients for the...
Following a patient who have undergone bladder preservation or chemo radiation in these stages, I have always
bad
seen
idea.
them do actually bad in the
It's a bad
long
idea.
run.
We also agree to that. But the
I'm doing a
literature,
panel discussion, so maybe let me start.
with that only, I think I would also be interested, because it's a bad idea, but the literature is still, there is literature in radiation data field, they say that they're able to manage this. And maybe we should ask, there's something from radiation oncologist.
Literature in the T2.
Yeah, and they're trying to extrapolate to T3, basically, nothing else. They're trying to just extrapolate it.
Yeah, thanks, Harshit. I think you also mentioned that you had OT case scheduled. In case it's not urgent, you can stay around, or we'll start with the panel discussion and we can involve you in the...
I got a permission for next 10:30, 9:30. Here it is 10:11 right now. So I've got permission till 10:30. So I'll be there in 10:30.
Around till you are able to, and I'll request Dr. Ganesh Bakshi to introduce his panelists and start the panel discussion.
Thank you.
Thank you.
Thank you so much, sir. Thank you.
Thank you, Ravi. Thanks for giving this opportunity. I think we'll come to a little bit of a clinical aspect of locally advanced bladder cancer. And since it was initially mentioned T3, I have a lot of T3 cases, but there are a lot of cases, and please feel free to stop me anytime you want. So the panelists are Dr. Bhalchandra Kashyapi, sir, who is from Pune, Dr. Anand Krishnan, who is our council member and from Chennai, Dr. Tarun Jindal, again a council member and from Kolkata, and Dr. Prashant Naik, who is the professor at AIIMS Bhubaneswar. So these are simple cases, and anybody is free to interrupt and discuss. That would probably make it even more better. And with the time constraint, let us stop anywhere we want. Some things are direct in the presentation. So this is a 65 years male, no comorbidities, presented with burning micturition and a sonography. This is one of the cases when I was in Tata Memorial, 5.9 by 4.8 centimeter bladder mass. And a CT was done, which again showed a right lateral wall 8.2 by 4.7. It was slightly undersized on the sonography, and an internal iliac node. So something like this kind was the mass. And these are the representative CT images. So many times we have a problem when we see this kind of a mass. And let me ask this question to Dr. Kashyapi, sir. Big masses seen in a bladder like this, what initially comes to your mind? What should you do?
We need to establish a histology. He doesn't have history of hematuria, so whether it's something like a variant histology. So we need a cystoscopy, TUR, biopsy, EUA, all three, and also get a prior, if possible, a staging, metastatic staging.
Okay, so that is how probably standardly we go. This was a CT picture, but what would be your choice of imaging if you are seeing this patient after the sonography?
I would have got an MR.
Okay. So this fellow had normal creatinine otherwise. So MR, as sir has rightly said, is a good investigation, and it's evolving probably. We all have problems with MR in certain stages, probably stage 1 or T1, to differentiate between T1 and T2. And if you see the T3, T4, it's, as you see here, it's quite easy to go on the MR. With the Virads criteria, it's slightly easy for the T3 and T4 to go on about management. So, Dr. Anand, sir has already answered. Would you do anything differently?
I think that's a reasonable way to go.
I mean, somebody would say that you put in a scope and it will keep on bleeding and bleeding and bleeding, and maybe you will have to do half TURBT, keep it in, do a full TURBT and get him again in the evening at 8 o'clock for a clot evacuation.
I think it's, just relying on an MR picture to make complete treatment decisions may not be appropriate. I think we definitely need some tissue diagnosis as well. So
Okay.
I would definitely consider cystoscopy.
So one question
It's already suggested TURBT. So I think that's reasonable to do. Right?
Should we bother about the lymph node? Or what would you suggest? What would be the criteria for the lymph node?
I think oftentimes I'm relying a lot on PET nowadays. But
Okay.
when we look at it has to be taken in conjunction along with the biopsy report as well as what we see on PET.
Okay. So you would do an upfront PET, because I had asked this question here, which investigation we would do. So you would do an upfront PET scan?
So here in Chennai, what happens is we get a PET with MR screen of that bladder. So they would give us an MRI of the bladder along with the PET as well. So that's what I'm relying on a lot these days. It gives you local staging of the bladder tumor as well as metastatic workup. But I don't rely only on the MRI. We would definitely do a TURBT to get a tissue diagnosis as well as a staging diagnosis before we take them up for any intervention.
Okay. So I'll leave this. Yes, sir. Go on.
I would plan not for a complete TURBT. Perhaps Anand also plans the same. Is to get an adequate tissue for a biopsy. It's a too large a mass. I'm not really aiming at a complete TURBT.
Sir, so suppose if it is clinically over T3,
yes.
I mean the other images showed a T3 picture in the bladder. That node, I don't have a short axis diameter, but it was 14 millimeters. So considering pelvic node of 8 millimeters.
Yeah.
So now, can we opt for NACT upfront?
Yeah, if it's a urothelial and he's a good candidate to receive, perhaps he doesn't have any comorbidity, I think he should be offered a neoadjuvant chemo and then consider for a surgery.
Okay. Dr. Prashant, can I
if
ask
I can ask a question before you ask me, Dr. Ganesh, this NACT, there is some recent evidence to suggest that probably NACT is something that works best for a T2 disease. If it is a T3 disease, T4 disease, already that window where NACT works is probably lost. Again, this evidence is conflicting with the previous results, which have shown that in NACT probably works well in T3, T4 disease. But there is some recent evidence to say that T3, T4 probably adjuvant is almost equal to neoadjuvant, because the disease is whatever micrometastatic disease. So T2 with NACT is probably better than T3, T4. But yes, I would consider NACT.
Dr. Prashant, I can even counter you saying that there is enough data coming up in the last 2 years in most conferences that in T2, N0, M0, you should not give upfront chemotherapy.
Yeah, that was the data that came out when we are battling this COVID also. That we
no, it is coming out right now. Even the last meeting it was there.
I agree.
So
but
I don't think we should have this debate of NACT in T2 or NACT in T3. If you have the ABC meta-analysis of NACT, you have a straightforward 8% benefit, and it's categorically those patients are T2, T3, T4, and particularly N0. So if you wanted to put the debate there, you should have probably said that. But if you just, what Dr. Harshit presented to us, I mean, most locally advanced tumors would again go for a NACT, right? So my question to you was, can we avoid a TURBT?
No, again, a histological diagnosis is important to me. I need to know whether it's a urothelial carcinoma before I go ahead. So
we have discussed this often in TMH, and such large tumors, we have actually have our own pathologist in board in these things. And actually such large tumors with a cytology positive of a high grade, we have gone ahead with chemotherapy actually, very honestly, in a MDT.
But you know, a cytology is very when it may be positive, it may be negative. Yeah, you can do a cytology, but there is no guarantee that cytology will pick up something.
I think
Fully
most
agreed.
medical oncologists
Anand?
may be hard pressed to give chemotherapy without a tissue
histology.
diagnosis. Yes.
I agree with you, but I said the clinical scenario which we had been following regularly in Tata Memorial, and with high grade, everybody knows the chance of cytology getting positive is more than 95%. The low grade ones is 16%, but a low grade probably at 8.2 centimeters is a yeah. So this was the next question, but I think we had the discussion. So in this particular patient, TUR biopsy was done, high grade LP muscle invasion. So Kashyapi sir, what would you go ahead with? You have already answered this question.
I would say neoadjuvant therapy followed by definitive therapy afterwards, the cystectomy.
Okay. I think, and what would be, Tarun, if you're there, what would be your ideal metastatic workup? Because Anant already gave a perspective from Chennai. I think I simply do something different.
So we usually go for a CECT chest and abdomen, but I would have to agree that FDG PET is the investigation which the patients themselves are getting done. So the patients themselves come with these reports often, but yeah, from my end, I would probably go for a CECT chest and abdomen.
I guess I think the guidelines, either NCC and European do agree with that. But I think upcoming role for PET is being said as Anand said. So we're just going ahead if we have the time. This is a 59-year-old gentleman, no comorbidities, gross painless hematuria, and has a lot of past history. So to cut short the past history, road traffic accident when he was very young, and erythroplasties and whatever urinary retention happened in March 22. Then self-catheterization was taught, and then finally this mass came to the light. Then a cystoscopy, and so the sonography showed a 4 centimeter mass, and the CT again showed a 5.4 centimeter of mass with perivesical extension and left-sided internal iliac lymph node. So the picture kind of looks like this. I think this is how, if you can see the arrow, looks like this. A lot of images. I think questions are very few. This is a PET CT because we all accepted that we will all do a PET CT. So there is no metastatic disease. The nodes are... The problem in this patient, though, when I put this slide was that just purposely that RTA history and lot of surgeries for that matter in the urethra were done when he was in a younger stage. And this fellow cannot hold the urine for more than 45 minutes. So that was his basic problem. And his life was absolutely miserable with a lot of surgeries, scars on the abdomen. And then this was done in Feb 23, a cystoscopy TURBT. That is the time when the tumor was seen, but it was not accessible because of that road traffic accident and later on surgeries. There was no reach by any chance. So it was high-grade urothelial squamoid differentiation, that means poorly differentiated. And so the question is, Tarun, what would you do in such a case?
I mean, this is a case of you can go for upfront surgery also in this case. I mean, you can go because the deep muscle is not invaded. So there's an evidence of squamoid differentiation which indicates
the imaging was like pretty bad. Like,
yeah, I agree. I mean, this patient might actually require because the node is there. This patient might require an adjuvant therapy. And now, I mean, there is a substantial evidence. There was a meta-analysis.
I am not opposing you for surgery. I just came back to the picture.
Right. So I will go for a cystectomy, sir. Despite it being inflamed, thickened bladder, I would go for a surgery, certainly.
So, Dr. Anant, you second that?
Yeah, there's node positive disease. Why don't we consider NACT on this case, Tarun?
Okay.
We can plan for, see, his life was miserable, 45 minutes, he can hold his urine, he has severe LUTs. And there is an evidence now available which says that adjuvant, I mean, there's a level 1 evidence which was in European neurology saying that adjuvant is as good as neoadjuvant. So why not going ahead with a surgery, making his life slightly better, and then consider adjuvant? I mean, neoadjuvant will not be wrong. It's just curtailing his
So I
symptoms.
agree with both the panelists that a neoadjuvant as well as going from upfront surgery and adjuvant probably we need to select patients here. Many of these patients would probably go for a neoadjuvant, as Dr. Anant is saying. This particular patient was quite miserable in the ward after the TURBT. He began with hematuria and then all these things happened. And he just could not retain. So we did operate him actually. It was finally PT4, N2, and 3 nodes positive. Obviously, those nodes were seen on the left side with the PET scan. So now this debate about NACT and adjuvant, we had already discussed in Dr. Harshit's presentation. But just to go ahead with what Dr. Anant was saying, there is a good benefit with NACT, and sometimes the problem is our inability to predict a response. Now, this patient had overt T3 disease seen. T4 in the histopathology was actually with the invasion of the prostate stroma, and the obturator lymph node was grossly positive. So with NACT, we can see response rates which are pretty as mentioned, and with acceptable CTCAE grade 3 toxicity of 55%. The question is sometimes raised is, what about the quality of life when we give NACT, and specifically to the point where Dr. Prashant was saying in T2 N0 M0. So just taking the discussion there. Tarun, what do you feel? Always, many times we see these NACT taking patients, they are quite, disturbed or they are sick.
Right, sir. So see, practical applicability in lot of retrospective reviews of NACT, I mean, even in the eligible patient has been to the tune of 30 to 40%. So why is that? We have to contemplate that. So the reason being, these patients either don't accept it, either they are suffering a lot, either they are having massive bleeds, and there are reasons why NACT is not beyond 80% of usage. So I believe, I mean, we have to be selective about it.
Right.
So it's like we always say cisplatin eligible or not. We should probably have something like chemo eligible or not, near
Chemo
eligible or not. Yes, because a lot of patients, either their logistic reasons, they're coming from outside their hometown or something like that. So they will not be able to have NACT a lot of times. So they may be candidates, we may not be able to give it to them. Right. So that's also something we should.
I mean, this particular patient, which needs to be given NACT for at least a span of 3 months, 3.5 months, with this bladder capacity and this symptoms, I think we have to titrate.
We will be more miserable with the neoadjuvant.
Correct.
Dr. Ganesh, can I add a small point here?
Yes, Ravi, please go on.
Yeah, DDMVAC, in fact, won't take that long, one. But I agree with the panelists. A great discussion going on why NAC is not utilized to an extent that it should have been. But DDMVAC, if it is being practiced, it typically takes 3 weeks for one cycle. So they would do 3 cycles. That would be 9 weeks. So that's done. But in this patient, I agree with the panelists. Just wanted to add that point, make that comment.
Okay. So coming back to Tarun, we operated the patient, like I come to you because you were ready to operate like me. So what about adjuvant therapy? Now, when would you start with adjuvant therapy, or when would you send your patient for adjuvant therapy?
So timeline?
Kind of.
So I tend to start within 4 to 6 weeks of surgery, because that is the amount of time which these people usually take to become clinically as well as biochemically fit. Biochemically, as in their reports start getting normal, their hemoglobin stabilize, their appetites become good. So nearly around 4 weeks from surgery.
Absolutely. Earlier, the better. But generally, many times the bladder operated patients do take a little bit of a time to recovery, or the full recovery does take a prolonged interval. I mean, it's slightly unpredictable which patient will go prolonged. And papers do say that it has survival benefit even when you can start it as late as up to 6 months. So this has been discussed in the lecture prior, but there is a role of adjuvant IO therapy with nivolumab, probably, with this Checkmate 274, which shows a new standard of care for patients with MIUC with high risk for recurrence despite neoadjuvant. So this is post-neoadjuvant. Any role you all feel in this kind of patient of adjuvant radiation? No, nobody feels.
Where the surgical margins positive? How much was the extravascular extension, especially anteriorly?
It was there, means T4, N0,
But
N2.
T4 was because of the prostate, you said.
Because of the prostate. But there was a T3 disease on the near the upper anterior. It was extravascular disease.
Again, the role of RT would be in those cases where you have left gross disease behind. I think that is the, or where sometimes the large lymph nodal masses are very difficult to remove. So when you do that, they're totally stuck to the wall and all that. So if you feel that something is left behind, and if the histology report also bears the fact that something is left behind, then I think there is a role for RT. So that is probably the only indication I would consider RT.
There's probably another gray zone in which RT can be considered if your apical margins are positive. So if your urethral margins are positive, the patient is not agreeing for surgery, then maybe RT.
Okay. So anybody else wants to contribute in that? Ravi, you want to say something?
I agree. So I think that's the right point, that if you typically what we would do in such a situation is if there is a perinodal extension or clearly T4, we also add radiotherapy to the pelvis apart from adjuvant chemotherapy. But I think it goes through MDT discussion before we go on there. But adjuvant chemo, there's no doubt. Radiation, if there is PT4 clearly and perinodal extension through MDT, we would subject the patient to radiation.
So I've got a question. Ganesh, how would you sequence this if you're planning RT?
So if you're planning RT, I think if you're giving adjuvant, you give first adjuvant and then give a small sensitizing radiation before you again give RT. So RT is next.
Yes. First chemo, because
first followed by RT.
Yeah.
Yes.
So initially, even the guidelines, European guidelines were very clear. Adjuvant chemotherapy has a role. There is no role for RT. And gradually, probably the words became little softer. When I left TMH, we have a trial of BART going on, which was about recurrences. And then we have a randomized trial with high-risk patients like these, which were randomized into only adjuvant chemotherapy versus chemotherapy and radiation. So it's still time for the trial. I mean, so it will take a time to tell. So that was basically designed to reduce recurrences in the loco-regional area. So the literature does say that patients with PT4 N1 disease have a 2-year risk of loco-regional failure that exceeds 30%, and they might be the most eligible patients to receive adjuvant radiation along with the other therapies.
Yeah.
Ganesh, in this patient,
Yes,
his
sir.
urethra is also going to be at risk. He's had a prior, you said urethral diverticle on one of the slides you have first.
Yes, sir.
So
Small
his
one.
urethra may also need to be observed very closely.
Yes, sir. Because PT4, currently we have referred for a adjuvant chemotherapy. So we thought urethra can be observed right now and done an interval urethrectomy.
Urethrectomy. So he needs to be counseled for that also.
Yes, sir. So should we go ahead? It's 9:10.
9, I think.
Okay.
Yeah, we can.
One case. So I think I'll just skip somewhere
quickly.
and go ahead. I don't know a lot of cases. I'll just try to give me a difficult. Okay, this is about local recurrences. We were saying just a contemporary cystectomy has a 5 to 15% probability of pelvic recurrences, which usually occurs during the first 24 months, and late recurrences can occur up to 5 years. Risk factors are pathological stage, lymph node, positive margins, and extent of lymph node dissection and peri-op chemo. As is distant, systemic recurrence is more common in locally advanced disease, T3, T4, and N+. So, we'll take this as a last case. This is a 95-year-old gentleman, known case of CKD, and was admitted for a generalized weakness. Otherwise, he was quite fit, goes to his own business in Mumbai and travels by the bus. So on evaluation, he has in Feb 23 left hydronephrosis, suspicious lesion in the sonography have left UVJ focal thickening at the same place inside the bladder, and a creat of 2.27. So CTKUB, right kidney 8.6 by 4.1, left kidney 9.1 by 5.2, urinary bladder thickening, left lateral or posterolateral wall with left UVJ, urine cytology, atypical cells, high-grade dysplasia. And then with that creat of 2.27, got done an MRI. There are few things which are seen here, but I don't know how to interpret this right now. This is seen slightly better. The thickening, it is shown here and it is here. So they also show a perivascular extension here. MRI, irregular nodular plaque, left side full thickness involvement of ipsilateral UVJ along with that bladder lesion, ipsilateral left hydroureter. How to advise? Dr. Prashant, would you like to take? He's ECOG 1 but has CKD 2.27.
So again, the suitability of undergoing anything, a systemic therapy, NSAT is kind of ruled out, because if you're not able to give cisplatin, then it doesn't make sense to give anything else. So creatinine is high, so is cisplatin ineligible, so you will not consider NSAT. So then again, we will have to assess the first is to get a histologist to plan for URBT and try to assess what that growth is. And if it's a urothelial carcinoma, it looks like it's muscle invasive and it is going beyond T3 disease. Then again, it has to be a discussion with the anesthetist and a multidisciplinary team discussion regarding what best we can do, whether we can operate or whether we can consider some kind of radiotherapy or not. But yeah.
So I'll come to Kashyapi sir. Sir, here the MRI was straightforward T3. Yeah. And we saw the ureter, which was hydroureter. Obviously, the cytology was negative, and we take on that what Prashant said, that we need a tissue.
We need a tissue diagnosis, but before that, you need to talk with the patient and the family. If the patient is well enough to understand everything, then many patients at his age, you will have a lot of relatives coming and saying, no, don't tell him anything, don't tell him he has a cancer and all that. So you need to first sit with the family and tell them these are what is standard, what can be considered, and then you will have to go ahead. Perhaps.
So my question is, what all options we have, considering that the biopsy has come urothelial free?
Yeah, if it's a urothelial, my option for him would be an IO instead of a chemo, assess the response, and then maybe consider for an radiation. Chemo, just a simple radiation, not the adding a chemo as a radiosensitizer. Because many times IO, if you see, if he's lucky, he might have a good response, and then you take it further.
Okay, Anand.
So you need to also mention to these patients and the family, the standard approach is a biopsy and perhaps a surgery. So if surgery, there is morbidity, mortality, everything is there. You will have to decide what diversion to you and everything.
So as sir rightly said, we are at 95 years with CKD, with tumor, cancer. only positive thing on the horizon is that the patient is still ECOG1. He manages on his own. His nutrition is okay. So Anand,
Patient
what
will
would
also
be
make
your
a decision
option?
for himself.
I would be thinking of cystoscopy, biopsy, and then possibly radiation, and nothing beyond that. Or, if he's not too symptomatic, ask him to come back in 6 months.
Okay. If patient wants surgery and is after you, what will you say?
To be honest, I've not operated on cystectomies beyond 80. So, I'm going to say radiation is your best option.
Yeah. So we'll end there, I think. We should evaluate elderly patients with G8 score or CCI or the clinical frailty scale, and probably in our practice use options which both Dr. Kashyapi sir and Dr. Anant had said. So it needs a good lot of discussion with the family, the patient, if patient knows about the diagnosis, and it is better that the patient knows about the diagnosis, and then take the most possible best foot forward probably. I think, thank you so much.
This
because
means 2-3 sessions of counseling.
I think back to you, Ravi. Thank you so much.
Yeah,
for the
before you end, there was one question which remains unanswered so far. That was a question by one of the members who has joined today. That is there a role of cytology, or you need to do always TURBT in locally advanced disease, that you just do cytology and start the patient on neoadjuvant chemotherapy versus
I think I'll answer that. So I said that in the beginning that in the MDTs which we used to have at Tata Memorial, where it was overtly big tumor and we got cytologists straightly positive, we are very confident about our pathologists back at TMH, so that we don't goof up with anything.
Do you have an age criteria for cystectomy? Do you kind of
in the literature, technically there is no age criteria. Probably that is why I had those. I tried to keep those slides, G8, frailty score, and all, and then we can use it, because the literature on all these criteria, they do say that comorbidities with respect to the human body and the aging would obviously affect the outcomes. So one thing is patient bearing the whole surgery, and the second thing is the actual outcome of the surgery, as well as then the oncological outcome.
Yeah, I think, yeah, thank you. Thank you, Dr. Harshit and Dr. Ganesh, for a wonderful discussion, one bringing up what is happening in the science, really discussing the challenging situations we face day to day. Sorry that I just got a report of COVID positive, and that's why I'm wearing a mask, because I'm at home. But I'm fine. I don't have any symptoms much. So as Dr. Amit reiterated right at the beginning, that it is essential for us to maintain, to ensure that we have a very good participation physically when we have annual meeting. So and its self-registration is the mandate. So I would urge every one of you to motivate yourself and your colleagues not to leave it at the last moment and get self-registered, and also try to become a member of USI Uro-Onco section, because it has a lot of advantages which come along being the member of it. So, and secondly, register for the meeting. So I think we would have one more webinar if everything falls in line. Or probably
we don't promise just now, but yes, we will.
Yeah. Otherwise, we definitely make an effort, every one of us, that we meet physically at Delhi in the Uro-Oncology, first Uro-Oncology subsection meeting. Thank you very much. Good night, everyone.
Thank you. Thank you all.
Thank you. Thank you very much.
So Ravi, abhi treatment kya hai?
Kuch nahi. They said wear a mask and continue working.
Achha, they allow you to work also. Okay, there is no isolation.
I just spoke to
no restriction.
The community medicine person. She said you can continue working if you wish. Otherwise, do a 48 hours quarantine if you don't have any fever, and continue working. That's it. So